Ahead and get us started. So I do want to say, just on behalf of the Practice Management Committee for Maryland ACEP, that welcoming everyone to this event. Not a surprise to anyone on this call, I'm sure. The opioid epidemic continues. However, what we can offer patients is evolving, and that's why I'm excited to present today's topic: advanced use of buprenorphine in the emergency department. And before we dive in, I also want to give a couple thanks to some important people, including, of course, Dr. Mike Silverman and Maryland ACEP leadership for supporting this committee, Adriana in particular for all of her efforts organizing and promoting this event, and of course our three esteemed speakers here, who I'll briefly introduce. I'll let them introduce themselves as well as they come to their talks. But Dr. Mustafa Saheed is the medical director for the emergency department at Johns Hopkins Hospital in downtown Baltimore, where he has been on faculty since 2010 and is a site champion for buprenorphine use. And he will be discussing best practices as it relates to buprenorphine. Dr. Drew Fuller is the founder and medical director of Brightwell Health, a comprehensive addiction medicine practice, and he is notably, for those who are not familiar with him, dual board certified in both addiction medicine and emergency medicine. And he will be discussing some advanced and expanded uses of buprenorphine. And last but not least, Dr. Gentry Wilkerson is an associate professor of emergency medicine at the University of Maryland. He is also our director of clinical research in the adult emergency department. And while he has many research interests, opioid addiction and treatment of opioid overdose has remained chief amongst them, certainly as long as I've known him. And he will be discussing what we as EM providers need to know about the new extended release injections of buprenorphine. So without further delay, I'm going to turn it over to our speakers. We'll start with Dr. Saheed. They have been, just so the group is aware, they've been asked to kind of limit their presentations to about 10 minutes apiece, so that we hopefully have the second half hour for kind of an open form of question and answer, as we all kind of learn quite a bit, I'm sure, about this topic. So Dr. Saheed, go ahead and take it away.
All right. Thanks, Dr. Gatz, for the lovely introduction. And I would just jump right in. Despite the fact that this is an era of Zoom, just want to make sure that everyone can see my screen well. Okay, I'm seeing nods, so that's good news. All right, so we'll just jump right into it. So one of the things, as I thought a little bit about this conversation about best practices for the management of opioid use disorder and for thinking through buprenorphine management, is just to really start first going back to the foundational change that had to occur in me. And I'm going to talk a little bit about my journey here, in that I had to really start to think thoughtfully about the medical disease model and really start to understand. For many of us who've been practicing emergency medicine, we've, particularly in parts of the city in Baltimore, but all throughout the state, we've encountered patients who suffer from polysubstance use disorder. And I'll be honest and transparent to say that it's not been with enthusiasm in the earlier phase of my practice. And if anything, it felt defeating. And as I reflect on this a little bit, I know that emergency medicine can be challenging because we often don't see the bright spots of people doing better. We often see cancer in the downslope, but never people healing. We often see the downside of disease, which doesn't really give us hope. And in our journey here at Hopkins, we engaged, and it was particularly poignant for us, peer recovery coaches. These are staff members who've had disease and opioid use exposure and or polysubstance use and have gone through, and for most of them are in remission and are currently in control of their disease. And having close relationships and collateral engagement and getting to understand how difficult that journey has been, but how people can make it through and do better despite the hiccups has been tremendously important. So the first thing I would say is it is really, really important to understand that this disease process is a tough disease process, but that there is light and hope at the end of the tunnel, and it's a cyclical, continual process that we have to help patients fight. Why is this important? I won't belabor everyone's point when we talk about data. This is all the way up to 2024 here, CDC provisional death rates that we're looking at here. And if you look in Maryland, we're talking mortality that are significant, and lots of our fellow citizens and patients have died from opioid use disorder. So, and while there's some trends for positive improvement over the country overall, we still have in Maryland some challenges in particular to overcome. So, what can we do in emergency medicine? At the heart of this is the concept that there are 3 or 4 practices broadly that we can implement that will help them make a difference. The concept was put together by Hawk et al. As a part of a writing consensus group for our ACEP, where they describe 3 strong tenets that I think are important. One is in emergency medicine, we can treat opioid withdrawal. We can offer buprenorphine, and by linking patients to ongoing medication-assisted treatment, we reduce morbidity and mortality overall. And I'm going to talk about best practices to get this started at your shop. First thing first, in discussing or thinking about opioid withdrawal, we'd be remiss if we didn't talk about who's in withdrawal and who should I be treating and how do I structure that. There are good data out there around the clinical opioid withdrawal scale. It's well validated. There are lots, probably other tools and lots of other, there's a NINS and a CIWA and a visual analog scale that have been around, but the COWS is probably the best validated studies, got good inter-rater reliability. It goes across multiple domains, from pulse rate to sweating to restlessness to pupil size to aches and pains, running noses. It's built out there in MD Calc, so it's easily accessible for the individual provider to run through, or even the nurse or nurse clinician, tech or technician to run through with a patient to assess. The scale itself goes through 5 through 12 with is mild, 13 to 24. The absolute number after you've completed the scale is considered moderate, and then there's moderate, severe, and severe. The most important number that I walk away is that patients generally greater than 8 have significant enough withdrawal that we should be considering treatment with buprenorphine and medication-assisted therapy overall. All right, so rolling up our sleeves. When we have a patient, who should we be treating? There are pathways and guidelines that we created in our own systems to help kind of facilitate this process of who should get buprenorphine. The first thing we need to understand from a best practice is that buprenorphine is a partial antagonist agonist. So what does that mean? If people have other opioids on board and we aren't careful about assessing the presence of other opioids, patients can be thrown into precipitated withdrawal. So that's the big issue. And that's the big thing that makes people nervous and scared with buprenorphine. But there are reasonable processes to assess and mitigate that. First thing first, simply engaging the patient and talking to them and asking them. Patients themselves in 2023, 24 are very familiar with the concept of withdrawal often and precipitated withdrawal, and understand the idea that when we ask them about recent use, it's helping to try to avoid this. So the patient's going to be forthcoming with you often. And what you want to know is, are they on methadone, which is has a long half-life? And so if they're on methadone and if they've used it within the past 2 to 3 days, they probably acutely, the standard dosing regimen for buprenorphine is probably not going to be appropriate for them. For those patients on methadone, that's not part of this talk today, but if they're in withdrawal, management with further methadone may be the appropriate strategy for that cohort. For other patients who are on other short-acting or moderate-acting opioids, generally 4 to 6 hours. If one wants to be careful, it can be as long as 8 to 12 hours to make sure that those other systems, those medications are out of those systems. And when you combine that cohort to ensure that you also use one of the withdrawal scales, if they're having active significant withdrawal and report having taken short-acting opioids greater than 4 to 6 hours ago, they would be in a ripe zone for appropriate treatment. One thing to keep in mind is folks still have this idea of treatment. If people have nausea, I give them a anti-nausea medicine. If they have shakes, I give them a little benzo. Ideally, we know that treating patients with either buprenorphine is gold standard. It's much more effective for helping to manage their withdrawal symptoms. So we strongly encourage it. So how do you dose it? For patients with withdrawal greater, COWS score greater than 8. We often start here at Hopkins with 4 to 8 milligrams, leaning more towards 8 milligram dosing. The secret to the sauce is really frequent reassessment and frequent dosing for patients who are having ongoing symptoms, so that as we dose the patient, we would reassess them in 30 to 60 minutes to see what their COWS are doing, what the patient's perception of their withdrawal are. If the patient's perception of withdrawal and their COWS still validate that they have severe ongoing withdrawal, we would redose with 4 to 8 milligrams and continue doing so until their withdrawal are under management. There are discussion points of even higher dosing of buprenorphine studies that have come out with doses as high as 12, 24, 38, with really no terrible side effects. The biggest fear is that because it's a mixed opioid, that could cause respiratory depression, but the data doesn't seem to bear that out, or at least early preliminary data. But ultimately, I think what we want you to walk away with is the importance of redosing and dosing patient to symptomatic relief. That's the point. We want patients to have their symptoms managed and to have it managed well, because then they have faith, they have confidence, they're engaged with you. And the data, again, reinforms that when the emergency department participates in this, patients are much more likely to seek care, to engage in care, and to continue with outpatient care. All right, so ultimately, how do you manage this as an individual practitioner? There are a couple of things to say. First thing first is the concept is you want to create a process of care, and you be the champion for your practice group. If your practice group doesn't already have structures in place to help make this easy, it doesn't have to be terribly complicated. We started off, and our earlier work with pathways with a sheet of paper, double-sided, with guidelines that are put right on there, because we find that when people have things right at their fingertips, it makes it easy. So start there. Send out an email to your group, with the blessing of your leadership and engagement, to make sure that they understand. Here are our simple guidelines. Here's COWS on one side. Here's a dosing strategy on the other side. And so people feel comfortable that they have that. Second piece is embrace the medical model. We want to talk not only to the prescribers, but you want to champion and engage your nursing teams to say, we have a role in this. Our data suggests that when we in emergency medicine get into this space with our patient population, and we see patients that no one else in healthcare sees, we save lives. We absolutely save lives by this engagement. And that's important to get out there, not only to the teams involved, but to the providers, as I said, but to your nurses, to your techs, to your security guards. You want everyone to engage, because the stigmatization is real, and what you want is to create a welcoming front for our patients, so that they can engage in emergency medicine in this space as well, so they don't feel alone and leave and not feel their part, that their care is just as important. Establishing protocols. It is really important that in addition to kind of this management protocol, dosing protocols we talked about, that you create maybe 1 or 2 local follow-up pathways to be able to refer patients to, because starting and managing patients in the emergency department, while it's very important, is very much facilitated by a warm handoff for care coordination. If we look at Maryland, despite kind of the doom and gloom, we know that our data suggests, and this is 2023 data here, that if we keep at it, right, we can make positive difference in this space, and you can see this positive trend going down. So imagine if we, as all individual emergency practices and practices across the board, engage in this space for our patients, we can continue to make meaningful positive difference. I'll pause there for a minute to allow my colleagues to share further.
Thank you so much. That was great. We'll move right into Dr. Fuller here.
Mustafa, that was fantastic, and thank you for being an advocate for that and moving that forward. And I'd like to take that baton and move it further down the street with a more specific question. And before I do that, I just want to give you some background. So I trained in internal medicine, then went back 5 years later, trained in emergency medicine, and I was lucky enough to get exposed to Peter Pronovost and the others at Hopkins, and patient safety became my passion. And it was doing patient safety that actually exposed me to opioid treatment, or treatment with buprenorphine, because I always felt like I was giving patients the Heisman when I was in the ED. And yet when I found out how effective treatments were, there was an epiphany, because I found that it was more effective than a lot of the treatments I was providing as an ED provider. And in doing so, started working for the local health department part-time, and then became the director for an opioid crisis response program, and since have opened up my private practice. Now, with that, I'm bringing forth a question to the group, and the question to the group is going to be, how comfortable are people in doing buprenorphine after overdoses? Because when I was the chief safety officer for EMA, we launched a Bupe project to 23 hospitals at once. And it was a hard thing to do because we saw a lot of variability between providers at a site. Some providers just said, I don't believe in this, I'm not going to do it. And then there was a lot of variability between different sites. So there's a big challenge there. But how do we take these best practices that Mustafa is talking about and others, and then bring them forward? And the reason I mention that is I see a lot of patients now that have experienced overdoses, and many of them have variable things to say. So I just want to move forward. I have really no disclosures other than the fact that I have a private practice, but I do want to emphasize what Mustafa said, and that is, people do emergency medicine because we want to make a difference. And, shout out to Steve here. You are heroes for what you do, from the fact that you take care of everyone else's catastrophes. And opioid overdose, we're talking about the opioid overdose crisis. Well, opioid overdose is a crisis. And then if you think about emergency physicians and providers, we are the crisis specialists. No one does it better. And so really focusing on the medical model that Mustafa talks about, if we look at the fact that it's an opioid medical crisis, what better group to help address that? I don't want to hit you with a bunch of stats, but I will share a few items with you. So opioid use disorder as a diagnosis, much more common than what we thought it was. And if you look at these national studies and they say it's about 1% of the population, that's when people get cold called and said, I'm from the government, do you use drugs? It's not surprising it's a 1%. But when you look at database analysis, it's closer to 4 to 6%, and that 6% is actually in rural counties. And if Maryland extrapolating that, it could be hundreds of thousands of people in Maryland with opioid use disorder. It probably doesn't surprise you with what you see in your emergency departments. I won't belabor the point with the stats, but I will just make the point is we're in a whole new era, and this whole new era is high potency synthetic opioids. And so the rules have changed. And so I would clarify that fentanyl has not contaminated the drug supply. It's completely replaced the drug supply. When we do drug testing, we almost never see heroin. It's almost always fentanyl. And so it's now the leading cause of death for people under 49. What's important for us to know in emergency medicine, even out in the community, is while this is obvious to us, well, it's a medical disorder, it's highly fatal, why don't we treat it with medicines? Still, only about 1 in 5 to 1 in 8 people are getting access to the gold standard treatments. And there's lots of reasons for that. We won't really go through it here. And if we're looking at that medical model that Mustafa was talking about, is the problem with this medical condition is that it's so fatal. And some stats say it's 5% fatality rate. Some say it can be as high as 10% fatality rate in 1 year. And when we look at it, like if people come into our hospitals and they have to be admitted and they have substance use disorder and they're not actually started on treatment, and then they're discharged from a hospital, not from an ED, but from a hospital, their overdose death rates skyrocket 1,500% higher than they would have been if they're out in just in the general community. So important things like that for us to keep in mind really, help elevate the importance of this. People come in, they have an overdose event, they come into our emergency department, we stabilize them or they leave. But that highest risk period after they leave our emergency departments is that first 48 hours. And some of those people will bounce back, but some of them, unfortunately, will have a fatal outcome. Mustafa mentioned that treatment in the ED actually doubles likelihood of follow-up. I won't go there, and there's lots of great resources for what we do. But here's the question I have for you, and the reason I bring this up is while there are lots of hospitals that have protocols, and there are lots of people that are becoming more comfortable with providing buprenorphine, there's a specific question that we have to ask ourselves is that the most vulnerable period of time for a lot of these patients is when and how do we provide buprenorphine after an overdose event? And especially if that overdose event happens where they had naloxone and they're already in naloxone precipitated withdrawal. And I've talked to ED leaders in the region, and some will say, well, we don't give buprenorphine to any of those patients. And so this is probably a good opportunity for the leadership of the state to say, hey, where can we look for these best practices and how can we help with knowledge transfer? And the reason I bring that up is because you've probably even heard that some EMS units are actually starting to do buprenorphine. And there's one in Frederick County, Annapolis City is starting to do that. There was a study out of New Jersey, and then I think a group in Philadelphia. And the question I would ask is why? I mean, why are EMS units doing buprenorphine? And the reason is, well, we don't really know. I mean, all together, but but one of the main reasons is patients don't stick around long enough necessarily to come to the emergency department, and they're vulnerable. But why don't they stick around? And they may stick around from past experiences, or they may stick around from just the belief that they're not going to be treated. And they may not be aware that conditions are actually changing and that they have the opportunity to be treated. So the question is, do they trust us? Well, maybe, but maybe not. And I've been doing private practice now for 2 years, and I was with the health department doing full time for about 2 years in addition to that. And I would say 95% of my patients say they weren't even offered buprenorphine when they were in the emergency department after an overdose event. So great opportunity for us to take this ball and move it down the road. One of the guys that's probably the thought leader in the country is Andrew Herring, who's an emergency physician and one of the principals of the California Bridge program, which I think they're now just calling themselves the Bridge program. And lots of great resources on that website. But he speaks specifically about buprenorphine after an overdose event. And in his term is that's go time. That is the absolute best time to start buprenorphine for someone after they've overdosed. They're already in precipitated withdrawal from the naloxone. Do it and do it quick, and then do it high. And so they have some high dose buprenorphine protocols out there. Where patients are given anywhere from 8 to 16 milligrams in that first dose. And again, this is after overdose. And then reassessed an hour later, and they can be given another 8 to 16 milligrams. So they can receive theoretically 32 milligrams of buprenorphine within an hour, and then followed with some observation. Lots of good studies support doing that, even for anybody else. There is a lot of concern in the emergency department. I think I'll just I won't jump ahead about buprenorphine precipitated withdrawal. I think people are really concerned about that. And Andrew and colleagues have shown that it's actually a much more rare event than what we're aware of, it's like less than 1%, especially if we go in the higher doses of buprenorphine. Buprenorphine precipitated withdrawal may actually happen with some of the lower doses. And I'm not talking microdosing where you're doing 0.25 and then moving up over a week, et cetera, on the outpatient basis. So just keep that in mind. Buprenorphine has greater affinity than any of these products here, including naloxone. So if someone comes in, they have naloxone blocking the receptor, giving buprenorphine can take that over. This is just a schematic is drawn by Andrew and others. But what they try to show is that someone, if you look to the left, here's the agonist effect of whatever substance is being used, and then there's withdrawal effects. They get naloxone, they get precipitated into withdrawal. And then if you can start, and this is an old drawing, you probably can update this one, and start by actually providing buprenorphine, you can take them out of some of that withdrawal. And then if you're really aggressive with it, you can help it take over and to have it be a comfortable experience for the person. This is a great resource that's out there, and there's just a reference for that less than 1% of buprenorphine precipitated withdrawal. I will just kind of move on from here. One of the challenges we have with EMS and our first responders, but even our ED docs, is compassion fatigue. People were so burnt out, and I felt like maybe I was burnt out as an emergency physician with opioid use disorder. But once we learned the fact that our treatments can make the difference for people's lives, it's a very rewarding experience. So, this is our chance. This is, we own this. We don't have to punt to the peers. When these patients come in, we can, have code overdose, right? If you think about all the resources and energy that gets put into a stroke patient and all the energy and training we had to do for thrombolytics for ischemic stroke, and it turns out thrombolytics probably aren't as beneficial as we thought they were. But just imagine if we put in that energy into a young person who has the potential for lots of years of life lost, they may have kids themselves. So the multi-generational benefit of aggressive treatment here. So we don't have to punt the ball. We can move this one down the field. And I'll close with just a few reminders. And it's the rule of 5 for opioid use disorder. It's 5 times more common than we thought it was. It's 5 times more deadly because of the fentanyloids, and they're not going anywhere. I can assure you that. They're just going to keep coming with the designer drugs. And then medical treatment with buprenorphine or methadone is 5 to 10 times more effective than any other treatment out there. And I have to emphasize the point, be very, very, very cautious with having the peers in the emergency department try to make disposition decisions for you. They may think that treatment means inpatient. There's no evidence that inpatient is better than outpatient. And if they go to an inpatient facility that tries to, quote, detox the patient, there's a 95% failure rate with doing that. So if they go inpatient, it get maintained on meds and then bridged. That's a different story. So treating addiction is very inspiring. I look forward to the day where there is actually a fellowship in emergency medicine for addiction disorders, because there's really a lot of room for that and a lot of excitement about the possibility of that. And then I would say with the emergency medicine, you guys are the ones leading the way, really for the whole community, to be frank. ED physicians, you're crisis specialists, and as Mustafa says, you're the ones out there saving lives. Post-overdose is a crisis with high fatality potential, and treatment with buprenorphine in the emergency department will make a difference in a lot of people's lives. And then the 2 questions that I will end with, and hopefully we can bring back after the Q&A period, is how do we increase access to buprenorphine, even high-dose buprenorphine, especially after an overdose? And then how do we increase reliability so that we know our teams are doing it the way we want to do it? How do we measure our success? And those are the questions I'll end with. And I thank you.
Excellent. Thank you, sir. Very powerful comments there. And I'm sure that'll generate some questions as we come back after this last part. But Dr. Wilkerson, why don't you take it away?
Yeah. Okay. Everybody can see the screen? Is it?
Yeah, it looks like you're in your presenter view.
How do I swap displays maybe? How's
There
that?
you go.
Looks
Perfect.
I did it?
Yep.
I'm a genius for once. I didn't have to use a 12-year-old to fix a computer issue. All right. Well, thanks a lot. It was great to hear that. It's tough following 2 great speakers. But seeing the football references during that last presentation, a little tough there, Drew. Yesterday was a tough game. So I'm really honored to be talking about extended release buprenorphine. As an emergency physician, I got to be honest, it wasn't really something that I felt I had a lot of expertise on. And I think most of us probably don't have a lot of expertise. So I think it's a topic that we need to know a little bit about so that we know what to expect when our patients come in who may be on it or maybe going on it soon. So today's talks, we've been talking about the treatments for opioid use disorder. And there's three. We all know methadone, the pure agonist, buprenorphine, the partial agonist, and naltrexone, the antagonist. And we're really focusing on that middle one there, buprenorphine, the partial agonist. Buprenorphine has had this path towards its use, widespread use today. It was first discovered in 1966 by this guy, John Lewis, who was a chemist in the United Kingdom, actually working on trying to find treatments for opioid use disorder. But it actually came to market as an analgesic, first in the United Kingdom under Tim Gzick back in 1977. And in the United States, it was first marketed as an analgesic under the brand name Buprenorphinex back in 1985. But they were really focused on using it as treatment for opioid use disorder. This guy, John Lewis, who discovered it, shared it with some people that were working at the Addiction Research Center, which was located in Lexington, Kentucky. You can see it there. This is where a lot of the initial research went on. Interestingly, this was housed on a campus with the Federal Bureau of Prisons. So most of the research was done on prisoners. I'm sure that there was nothing ethical problems there, but also interesting, the Addiction Research Center moved to Baltimore in the 1974, and it's now known as NIDA. So moved to the DC area, and NIDA started out as this Addiction Research Center. So moving on, we've had a lot of information that's come on about buprenorphine and some of the laws and regulations surrounding it. Luckily, a lot of that stuff has been removed. And most recently, the Mainstreaming Addiction Treatment Act of 2022 really removed a lot of the barriers. So we really need to get comfortable with the idea of buprenorphine in the emergency department. So obviously, there's a lot of benefits with buprenorphine. We know compared to methadone, there's decreased facility visits, there's greater autonomy, so patients can go on trips and travel. They don't really have to need the willpower to adhere to daily formulations if they're using the long-acting. The problem with buprenorphine, as with any kind of a partial or full agonist treatment for opioid use disorder, is there's a risk of diversion. There's a risk of low adherence and people dropping out. So that's why there's been a push towards getting these long-acting formulations out there so that you have greater adherence and you reduce the barriers there are to care. So the first long-acting that came on the market was probufene. This was an interesting way of doing it, and it's basically an implant that gets inserted underneath the skin. And here we see a picture of that. Basically, it was approved by the FDA back in 2016. It's a dose equivalent of 80 milligrams, but delivers it at a dose of 1 to 1.3 milligrams per day. And that's about equivalent to 8 milligrams of a sublingual buprenorphine dose. These implants would stay in place for up to 6 months, and they reached steady state plasma concentration in about 4 weeks. So it actually took a little bit of time for them to get up to therapeutic doses. And unfortunately, or fortunately, now that there's other products, this was discontinued in 2020. They just couldn't find a market for it. And they came up against another long-acting medication that we'll talk about in a second. So they were both fighting in the same space. And this formulation just wasn't going to work as well as the next one, which is Sublocade. So Sublocade is a subcutaneous extended release injection. It received FDA approval in 2017. It was approved for patients who had already initiated treatment with buprenorphine, and they had to be on it for at least 7 days before they can go on Sublocade. It's kind of got an interesting way that it works. So Sublocade, the suspension, is injected into the subcutaneous space, and it rapidly forms a solid. So polymers respond to water by precipitating and trapping Sublocade into a solid implant. And then over time, there is a controlled drug release. So these biodegradable polymers degrade by hydrolysis and slowly release the Sublocade, which is very interesting. So the way it's used, you got to have at least 26 days between doses. So these are month-long injections, and patients get initiated on 300 milligrams, and that goes for 2 months. So they get 2 injections of that, and then they get started on maintenance dosing of 100 milligrams a month. Patients that are finding that they have an inadequate response, that maintenance dose can be increased and kept at 300 milligrams every month. The literature behind this was mostly from this paper that was published in Lancet in 2019 by Haight et al. And basically they had 504 patients who were enrolled in this study, and 201 were given Bupe-XR at 300 milligrams initial and maintenance of 300 milligrams. Another 203 patients were given 300 milligrams initial dosing and then maintained at 100 milligrams. And then they did have a placebo arm in this study, which I thought was kind of interesting, that they were able to get the IRB to approve a placebo-armed study when it's pretty well established that buprenorphine saves lives. I think that's a little questionable. I'm not sure if that was the right way to go about that. But here's the data from that. And basically what we're seeing is the number of participants that are engaged in the study over time. And they went out to 24 weeks. And you can see the purple and red lines at the top, much more engagement over time compared to the placebo group, which rapidly dropped off and stayed low over time. And then looking at the percent weeks abstinence by the injection type, basically there was no difference between the 300 and 300 group to the 300 and maintenance of 100 milligram. So 41 and 43% abstinence rate, whereas placebo, 5% abstinence rate. So placebo obviously didn't work well. No big surprise there. And then looking at the urine drug screens, here we see all the patients and their urine drug screens over time. And the opioid negative drug screens are in green, and the opioid positive drug screens are in orange. And we can see in the placebo group, there's a whole lot of orange there. And in the other groups, there's a lot more green. So just visually, it really shows you that the patients that are getting this medication are abstaining from opioid use a whole lot more than they would if they were not taking it. So that brings us to the newest long-acting formulation of buprenorphine, and that's sold under the brand name of Brixadi. So basically, Brixadi is another injection that can be given either as a monthly or a weekly formulation. It was approved just in 2023. It's only approved through a risk evaluation and mitigation process, so a REMS program. So, and it can only be administered by healthcare providers in a healthcare setting. And the healthcare providers and the setting have to be registered by this REMS program. You can't just start giving this medication. You have to be registered and follow their rules around this. So the way Brixadi works, kind of similar to the other, it forms this liquid crystalline gel upon contact with body fluids. And that actually can be a problem. And one of the reasons it's in this REMS program, if it's accidentally injected intravenously, then that gel can then cause tissue damage, occlusive events, including life-threatening pulmonary emboli. So they want to make sure that it's being given in an appropriate setting. So it's available in a whole bunch of different formulations, depending on the dose of buprenorphine that the patients were previously on. The data that this was all based on came from some early studies by a group that was headed by Michelle Lothwell and some others. But this first publication by Walsh et al. Looked at buprenorphine weekly depot and the hydromorphone blockade. So basically, they took patients, started them on this weekly dose of buprenorphine, and then gave them hydromorphone and asked them how it made them feel. And basically, it blocked the effects of it, and they weren't feeling a lot of euphoria from it. There was not a lot of desire to do it again. So here we can see their peak score and their outcome measures. Once that injection was given, they basically didn't have a desire to have more hydromorphone. So it seemed to be effective for that. So then looking, the same study group then published this article in JAMA Internal Medicine in 2018, looking at the use of this medication. Basically, they randomized 46 patients to get this versus, I'm trying to remember if this was placebo. Sorry, I'm forgetting on that. But basically, they were looking at urine drug screens and the rate of positivity. And what they did show is that there was no difference in the dosing groups of their long-acting buprenorphine, but it was significantly better than the group that didn't get the long-acting. There it is. So here we're seeing the, oh yeah, that's right, I'm sorry. They were comparing it to the sublingual buprenorphine and naltrexone, and they were showing a much better proportion of patients that got the opioid negative, had opioid negative urine samples, a 6.7% difference. So that was non-inferior. And then the response rates, and they defined response rates as having an opioid negative urine sample and saying that they were abstaining. So we're seeing a 3% difference there, also a non-inferior result. And here's the dosing of Brixadi that's recommended based on the daily dose of sublingual buprenorphine that they're using. And that's basically the data that I have on this long-acting buprenorphine. So we need to be aware that it's out there. Patients may be coming to you on it, and we're going to have to, one, think about how we're treating patients, especially if they're coming in with an acute complication of something. Yeah, we need to be aware of it, and if we're giving other medications, especially if they're QTC prolonging, that's something to consider, because these have been shown to prolong QTC as well. So just think about things like that. And I think we're ready for the QA session now.
Yeah, thank you so much, Dr. Wilkerson. What I will do is, if you just want to stop sharing there, we'll bring everyone up and kind of open it up to questions to any of our speakers. Feel free to either just kind of raise your hand on Zoom and we can call you out, or if you want to enter questions into the chat too, if that's easier. Any of those are totally appropriate. Otherwise, I'll certainly kick off with some questions because I have plenty. But give an opportunity for questions from the audience here.
Well, I'll ask a question then. Since I've got my colleagues from the private practice world and from Hopkins, I'm interested in precipitated withdrawal with initiation of buprenorphine. We've seen the data that's come out of the Herring and D'Onofrio Hawk group that says that it's less than 1%. I have questions about that. I'm wondering what you guys see over at Hopkins. We have some anecdotal evidence that it's much higher than that rate. We're hopefully going to be doing a study on that to actually figure out. But I'm wondering what your experience is either in private practice or at Hopkins.
Yeah, go ahead, Dr. Fuller.
I'll let Mustafa speak first.
Yeah, it's interesting. That's a really good question. We don't have unfortunately, perfect finger on the pulse of exactly how bad it is. I will say anecdotally, I tend to think it's got to be less than the 5% when 2%. It's on the low end for us, simply because when I'm thinking about those who are that we're initiating our protocols on, it seems on the lower end. I also say though that our patient populations are so keyed into it in terms of being nervous about precipitated withdrawal that I find that they would vary patients. I think maybe perhaps when we first started thinking about buprenorphine, we may have had a different, kind of rate. Now in 2024, any patient who's really concerned that they used recently or could be thrown in withdrawal, just simply decline buprenorphine. They will tell you, no, thank you. So I do think it's on the 1% range now for us. So I don't know if it started there.
Yeah, and I would say that that did seem, it surprised me to see that stat that it would be that low, but, and I also wondered, not only is it the selective process, but is it because they're doing high dose? I don't have that necessarily that luxury in a private practice setting. We tend to start people on microdosing and have them work their way up unless they come to us and are already in significant withdrawal. So.
Excellent, thank you. Dr. Schenkel.
Sure, thank you so much. Drew, thanks for the picture. I'm humbled. Two questions for Mustafa, Drew, anybody else who wants to kick in. Points of transition always prove to be challenging. And with BUP initiation, there's sort of two obvious points of transition. One is discharge and one is the admission. Something like 70% or more of our treatment programs in the city are non-medicated treatment programs. So for me to initiate buprenorphine and to send someone into a non-medicated program seems problematic. Yeah. Likewise, every now and then we do actually admit people often for other reasons, but with associated opioid addiction or withdrawal. And I have had exactly zero success in initiating buprenorphine for someone who's about to be hospitalized with conviction that it'll be continued upstairs. Have you found solutions to either of those?
I can tackle the hospitalized piece, and of course, we're guilty of being in a big academic site where realizing that inpatient teams had significant fear or anxiety or concerns around this space. We at Hopkins had put together a substance use disorder consult team that really is a combination of people who are addiction medicine specialists and toxicologists and all sorts of folks in that space who serve, and pharmacists actually, who serve as a repository of kind of knowledge for folks across the hospital. So that makes the handoff a little bit easier. So if I'm hospitalizing the patients, folks on different services have that resource that they can eventually consult. So I'm pretty confident that they'll continue. To your point, though, that doesn't exist everywhere, right? And so I think it is important to, we're talking about systems-based practice, to be the champion and advocate for, at least starting with the hospitalist service in terms of making sure that they have repositories of expertise in that space so that they feel comfortable that they'll continue your handoff. I see, Drew, you're shaking your head in that space.
Yeah, absolutely. Absolutely. Sorry, I was clearing my throat, but yeah, absolutely. And it's interesting is that if you can demonstrate to the inpatient service that you've already medicated them in the emergency department, it's well tolerated, and it's such a safe medication. There are really no true buprenorphine overdoses by itself. And then even if people are combining it with other sedatives, it's really hard. And if you look at the data on buprenorphine associated overdose deaths, these are really people who probably took some buprenorphine and they were taking a lot of fentanyl or other things and then overdosed and died. And I think like 93% of even that group wasn't even in a buprenorphine treatment program. So, and then the respiratory suppression with buprenorphine happens within the first 4 milligrams. So after that, and it's not significant for the most part. And so it's such a safe medication. So the patient safety issue, and I'm sorry if I keep harping on patient safety, but the patient safety issue with buprenorphine is in not providing it, either with a prescription where people be discharged or being discharged, that initial dose in the ED, or when they're trying to get them up into the inpatient services. What's is interesting is that those groups that did the microdosing, those Bernese methods, and a lot of that data was actually done on inpatient services, or when people were inpatient in a hospital. So the inpatient service may have a little more flexibility of putting someone on a full dose agonist orally, and then if they're going to be there for several days, like say they have endocarditis or cellulitis or pneumonia, then start doing microdosing and bring their doses up. But if you don't mind if I speak to
Oh, go ahead.
I was going to speak to the point of now you have someone in the emergency department and you're looking to start a dose there and then bridge their therapy to have them go. And Stephanie DeBoulis is on the phone, and she and I were kind of hesitant when the health department came to us, 2016, 2017. And we were giving them the Heisman, at least I was. And we felt like it was a bridge to nowhere because we weren't really sure what was going to happen to the patients. And luckily nowadays, there are more and more treatment groups that are out there. Some of the big challenges is absolutely do not, if you can avoid sending to a facility that is not medication centric, an OTP or even a methadone clinic is better than nothing, but people can probably, I will say this, buprenorphine is as effective as methadone, and so don't let anyone tell you it's not. And if you look at the Cochrane reviews and others that say methadone is more effective, intermediate dose, which means 16 milligrams, 8 to 16 milligrams of buprenorphine or higher, is as effective as methadone. It's low dose buprenorphine as an outpatient is not as effective as methadone. So yes, subtherapeutic buprenorphine is not as good as methadone. So if you're going to send them to an OTP, just make sure that they're willing to continue the buprenorphine. But I would say this: find a trusted 2 or 3 partners you guys can do, and then just send the patients. There are a lot of patients, a lot of places take walk-ins. The health departments will facilitate this. Anne Arundel County has a hotline, they'll facilitate that. I actually get most of my patients from the health department and word of mouth. But you find those trusted partners and they'll redirect them from there.
Yeah, we've also had to build in, just because the trusted partners are there, and that's the beautiful part about buprenorphine, because the practice model for buprenorphine can be so much more expansive as compared to methadone, where there's still more restrictions on who can administer and where you can pick up your methadone and all those details. Buprenorphine is much more easier to find folks in the practice model, like as Dr. Fuller commented on. What we had to do is we built out a bridge prescription into our systems and pathways, so that in case this is a Friday or a Thursday, if it's a patient who's super motivated, has a stable dose, doing well, we would provide them a bridge prescription up until that they can follow up and do the warm handoff with one of several groups that we established kind of set linkage with, so that they could follow up. And so our aftercare clinic, for example, which is a clinic that can follow up with ED patients, the clinician champion there as an internist was very much motivated to make sure that we can kind of engage with our patients on this front. So establish yourself as a backdoor. But to Dr. Fuller's point, there are other prescribers that are out there, and you probably need just a few for your practice to be able to send patients to. And with a bridging prescription for off hours, it could be a very smooth transition.
Good point. And be generous. So 3 days, 5 days, 7 days. I mean, I think the longer you make the prescriptions, does it increase the potential that someone comes to the emergency department so they can get bupe and sell it? Well, I don't think anyone wants to wait in the emergency department for 8 hours just so they can get a couple of doses of buprenorphine and go sell it. It's just not worth it for people. And then even if someone does get it and divert it, there is lots of good evidence that people that are buying the buprenorphine and using it, they're using it for withdrawal maintenance. They have lower overdose fatality rates and lower overdose rates. Diversion is going to happen. It's nothing to run from. So again, the patient safety issue here is not providing the buprenorphine.
Yeah. All right. I want to make sure we move on to some additional questions as well. I know you've been patiently waiting. Forgive me, correct my pronunciation here, but Dr. Amanda Aline.
Actually, I'm not a physician. I'm a nurse. I'm a quality manager in the emergency department at Children's. And so I wanted to know, this is great information. Is there anything from a pediatric perspective or any literature with regards to using these medications in the pediatric population? Thank you.
Mustafa, do you mind if I speak to that?
Yeah, you can jump onto it.
Yeah, so the treatment of choice for adolescents with severe opioid use disorder is buprenorphine. And the percentage of kids that have that, or adolescents that have that diagnosis that get buprenorphine, is closer to 0% than it is 1%. So safe molecule, lots of places won't take kids. You just have to find the places that will. The FDA initial studies were done on 16-year-olds. But there's really no reason it can't be done on a 15-year-old. If you have I have lots of patients that start using heroin and fentanyl at age 13, 14, 15, even injection drug users at that age. So, it's a risk analysis, right? Where are they going to be safer? They're going to be safer with buprenorphine than they are with fentanyl, especially. And I like the term from the DEA, one pill can kill. That's one pill of, people buying, of, illicit fentanyl or oxycodone. They think it's oxycodone. So
Thank you.
Excellent. I'll bring our attention to, I think, a question in the chat. The link to substance use disorder ongoing treatment is so important to successful clinical treatment and ongoing abstinence. How can we incubate in Maryland solutions that increase substance use disorder medication treatment programs into which these patients can transition?
It's an interesting question, and I think the state health department is really primed in this space and focused on this. And I think part of the challenges I see is, I'm not sure the absolute number matchup, so this is something worth investigating, but that there's a dearth of certain spaces for resources, so that if you are in Baltimore City, for example, probably have much more per capita substance use treatment than if perhaps you moved out to more of our suburban areas. So how do you also kind of spread the resources to fully match need is a big question as well. I will say in our collaboration with our state health departments, there have been super high engagement levels. And I think starting off from there in your local environment with your state health department, your your county health departments is going to be a critical collaboration.
yeah, my recommendation as well. Go for the county health department. They know.
Excellent.
Want help, they sometimes just don't know how to engage. And so if you're asking them questions, they may have resources that they don't know that you need, and can help kind of make the connections that already exist.
Gentry, I see you have internet again, so I'm going to call you out here. I am curious because you put together that head-to-head trial that said, you know, these long-acting options potentially are better than our daily sublingual dosing that we were just talking about prescribing. And I always like to use the best. So I guess I'm curious, are there any emergency departments, or is there a role in the ED to say, let's skip, you know, prescribing 3, 5, 7 days? Can I give patients a long-acting buprenorphine dose in the ED? Is that a thing?
So while the absolute numbers were better for the long-acting, looking at the confidence intervals, it didn't show superiority, and it wasn't designed to show superiority. So I would hesitate to say that the long-acting is better based on those studies. I think that for patients, my opinion is patients that are stable on buprenorphine, they probably have some benefit on being on a long-acting. So it may be right for them. As far as starting people in the emergency department on a long-acting, I don't think we're there yet. People are doing studies on that. Again, looking at Andrew Herring and Gail D'Onofrio, Catherine Hawk, that group is doing research in that field. They may show that there's some benefit. There has been research looking at the patient's perspective on it, and while they may do better in some regards, they actually prefer the daily dosing. I've seen some literature on that.
Well, part of it, and this is going to be an interesting, to Dr. Wilkinson's point, this is going to be a very interesting area of research, because there's that initial titration of trying to find the right dose for the patient that's going to manage their symptoms. And so I wonder if that's part of that, conversation. So I think in the next several years, we're going to be in a place where we'll either transition very much so, or it's going to be an option for certain patient populations, and we'll better define who's likely to benefit. I agree.
Yeah,
it's exciting to think
it's
about.
exciting. Yeah, and what you will see is if people come in, so I have about 100 patients on the Sublocade right now, and we will be going with the other products. But one thing I will say, if you do have a patient show up in your emergency department on Sublocade, has an acute trauma, needs pain medication, just treat them like you would anybody else. There are enough opioid receptors that still aren't being occupied. Make that point. The other point is a lot of these older studies that we're thinking, oh, you're occupying so many receptors at 8 milligrams and 16 milligrams. But if you look at Greenwald's data, that was at peak time of dosing, and then you have to really think about trough. And so high dose therapy is even as an outpatient in this day and age is starting where we're shifting to daily dosing of 32 milligrams or more. And one of the things to think about with buprenorphine is, yeah, it helps with cravings. So if your cravings are controlled, you're less likely to end up using. But compulsions are compulsions, and people still will end up using, whether they stop the dose and use or whether they continue the dose and use. If you have a high enough dose, you're more likely to have a decrease in what's called drug liking, which is one of the scales that Mustafa was showing with that VAS scale. And then the other thing to keep in mind is it's a overdose protection effect. So if your doses are high enough, there's actually studies that show that if people are exposed to fentanyl, they have a lot less respiratory depression. So it's cravings, it's decreasing drug liking, and it's opioid blockade with buprenorphine.
Well, that's great info. I am going to pause this because we have hit 1 o'clock, which is technically our end time. So I'm going to pause and say that if anyone does need to duck out, I know many people probably have 1 o'clock meetings. By all means, please feel comfortable doing so. If our speakers are able to remain on for a little bit extra Q&A, this will be a recorded thing that other people can catch up on. I know I personally have some additional questions, but happy to let anyone else step in here as well. I know Dr. Mann, you had some questions as well that you're just posting in the chat there.
Yeah, I was just asking, I mean, obviously you just answered the question, Dr. Fuller, that right now, or I guess Dr. Wilkerson, you answered the question, there really isn't the opportunity to get access to long-acting bupe for our patients. And I was asking Dr. Fuller, do you have access to it? Are you using it? Is anybody?
Oh, yeah.
In the emergency medicine context or in your private practice, just for clarification?
Are you asking me as Dr. Fuller either?
Oh, I was asking Dr. Fuller.
Yeah.
Sorry, just to clarify if it's in the ED context.
Well, I'm exclusively outpatient now, so I do it. But I'm excited to see the research that goes on, because I think it will be something that we use in emergency departments down the road.
Yeah, I agree. I'm not aware of any emergency departments who are using it as a routine standard of kind of care right now through the ED. There are lots of barriers and insurance challenges and all sorts of things that make it difficult to do in that context. Yeah, but boy, I just know that it's going to be part of our options. Unless the research bears out some complications we didn't anticipate.
Dr. Fuller, are you going to be switching patients to Brixadi now that that's on the market?
I don't know about that. I mean, the advantages of Sublocade is we know it and we use it, and I have a ton of it. But it's painful. It's a big deposition. We think we figured out a way to make it a lot better with patients by doing cold packs. But the Brixadi looks like it's a smaller volume, smaller needle, more sites to inject. So we're eager to try it. I'm a little bit concerned about the area under the curve if you look at some of their data about when they're covering the receptors or not. So we again, you can tell I'm a fan of high dose therapy. We still give sublingual buprenorphine until we reach steady state with Sublocade. So I will still provide sublingual buprenorphine for the first 4 or 5 months, and decreasing doses with every time we give it an injection of Sublocade. But it's exciting stuff. Now, I will share with you, there's 2 groups of patients that I give Sublocade to. One is the unstable patient that is continuing to be fentanyl positive, or they're actively using cocaine. And these are the people that I want to just make sure I'm getting those receptors blocked or occupied as much as possible. So in case they do stop the sublinguals, they have some protection. And so we're seeing some benefit with that. And so if we stick with people, it provides them enough benefit where they have decrease in drug liking over time. They're less likely to have that compulsive use. The other population is just convenience. They're just tired of putting something under their tongue, and Suboxone's a nasty bitter pill or strip.
I've heard, I think at this point, all of you kind of reference the fact that we don't, as providers, need to be afraid of these higher doses of buprenorphine. So if let's say I do have a scenario where someone comes in, they've gotten the typical 16 milligrams of intranasal naloxone pre-hospital, and now they're in that precipitated withdrawal. I give them 32 milligrams of buprenorphine here in the ED. What kind of a dose am I sending that patient out on? I mean, if I've taken like 32 to treat their symptoms, am I just sending them out on 8, or am I gonna be looking at a higher dose? I guess I don't know, how do I calculate? I don't know if that's built into your protocols somehow at Hopkins in terms of how you're deciding how much are you sending that patient out on?
That's a really good question. We aren't, it's complicated. Our overdose patients, we haven't gotten to a great place in terms of active bupe initiation for people who've come in with acute overdose, to be honest. Part of it is getting patients to stay and be there and engage is really difficult once they got the precipitated withdrawal. And so often half the challenge is getting them to come. And I think, or after they come, getting them to stay a little bit longer. Or after they stay, getting them to have faith that there's something we can do that's not going to make them sick because they've lost faith in that process already. So we rarely are in a place where we're giving max dose bupe in that cohort. I will say for patients who have required just from a natural withdrawal, as opposed to a withdrawal that was instigated by naloxone, like high doses of bupes to get them there, then we give them a prescription for high doses of bupe because that's what they needed, and that's just a final analysis. So to answer your question circuitously, the answer is if bupe is what's managing them, the fear of high dose bupe is, as Dr. Fuller pointed out, is really this thought that it's an opioid at the end of the day, and am I going to put them at risk for respiratory depression? But data keep reinforcing that patients they're not at that risk, and they're much more at the risk of respiratory depression from going on and using fentanyl. So we have to change that paradigm and give them the bupe, because that's not going to be the challenge. So.
Yeah, or they're going to be higher risk for dropping out of treatment because you're giving them a subtherapeutic dose, and then they're going to forever and ever they're going to say bupe doesn't work for me.
Yeah.
Exactly. And if we say, once again, the patient safety issue, there's no way of knowing what the perfect dose is. But what's the risk of underdosing buprenorphine? It's cravings and use and possible exposure and overdose. What's the risk of maybe that too high a dose of buprenorphine? It's they pee more buprenorphine. Really you poop, but that's the truth. And some constipation, but that's really it. They've done studies where people got 100 milligrams of buprenorphine and they're still sitting at the table having a conversation. So what I would say for what are the protocols when people are leaving? If someone was just using 50 to milligrams of oxycodone a day and they got an accidental exposure to fentanyl, okay, 8 milligrams twice a day of Suboxone should be fine, or Subutex, whichever they prefer. Suboxone has the advantage that they don't need a prior auth for the second prescription. But if it's anybody else, regular fentanyl user, my go-to now is at least 12 milligrams twice a day. And I have a large number of patients on 32 milligrams or more. And the reason I say 32 is you don't need a prior authorization to do 2 12s and an 8. You don't need an approval for it. I would say that prior authorizations are almost always granted. And so it's kind of a weird barrier. They almost never say no. But if you want to go to 36 milligrams a day, it's still going to be fine, but they would need a prior auth, so I wouldn't recommend that from the ED.
That's a helpful point.
You're speaking a foreign language to emergency physicians when you say prior auth. We don't know what that means. Thankfully.
Yeah, it just means so they show up to get their prescription and the pharmacist won't fill it because someone didn't call Medicaid to say, hey, can we do this? And Medicaid's good about saying yes to it, but they still put that barrier up there. So if you do Suboxone under 3 a day for a particular dose, or under 32 milligrams, you don't need a prior authorization. And then Subutex, which is pure buprenorphine hydrochloride, which we used to use just with pregnant patients. There are a significant number of people that could have a little bit more absorption of that naloxone component for it, and they may have some legitimate symptomatology from that. So if they prefer Subutex, that's fine. I've met 2 patients that have injected buprenorphine over the years. I've taken care of more patients that have abused the spray cleaner for my keyboard than have injected Subutex that I know about.
Good anecdotes.
Yeah, we do slightly prefer Suboxones here, I think, only because of that theoretical risk. But to your point, again, it's all managing risk.
Yeah. Yeah, I do want to go to one question that got sent to me. So let's say for you guys, your dream comes true and buprenorphine use is rampant for treatment. I like the dog through all of Baltimore. I guess one of the concerns that I have heard is with some of these long-acting agents, let's say someone comes in for something that's causing acute severe pain. They have a broken leg, or I'm thinking of one case where I actually had someone who, unfortunately, their hair had caught fire. So they had these bad burns all over their head. They were on buprenorphine. How does that impact our ability to manage these patients' acute pain?
So
Yeah.
I'll cover that first. So, there's no guidelines that tell us exactly what to do. And there's different ways that you can approach this. You can give them something other than an opioid. So somebody that set their hair on fire, maybe ketamine might be a good choice for them. Getting them on a ketamine infusion, or giving them more buprenorphine, or giving them a full agonist. All the receptors are not bound, so you've still got some benefit by giving them additional medications, or going completely different and going something like ketamine.
I agree. Our standard is to just remind people that you just may have to give a little more, and that's okay. You know, we have patients who, even for example, our sickle cell cohort, who clearly have a lot of pain, but maybe because of risk of abuse in the past, are on buprenorphine standards for the management of their pain. And so we know that it's, even though it's a partial agonist, it does have some analgesic effect, and we titrate up the buprenorphine for treatment of their pain. And so it isn't, to Dr. Wilkerson's point, it's not insane to say give them more puke, but if they're in an acute, broken bone, burn, we would overwhelm them with full-on agonists, and patients will do just fine.
Exactly. And don't forget, there's no dosing ceiling for the analgesic effect for buprenorphine. So you can go high dose buprenorphine, you can do IV buprenorphine, or you can do parenteral full agonist.
And Mustafa mentioned the sickle cell population, which I think is a great population to think about. And Hopkins has been one of the leaders in the country on transitioning patients with sickle cell onto buprenorphine. They're changing the management of chronic pain and sickle cell disease. It's really great to see what's been coming out of Hopkins. You guys are doing great work on that.
All right. I'll give another moment here for anyone else that has any additional questions. I appreciate those of you that stuck on for the Sexter window period. If not seeing any, again, I'll just thank, first of all, yeah, please go ahead.
Just one final comment. I would say that the MedChi, the opioid committee, is really interested in collaborating in any way. If there is a leader within Maryland ACEP that wants to take on the focus concept of bupe after overdose, and this try to help Maryland standardize the process with resources and expectations or measures, Maryland can literally lead the country in this if it wants to. So I think the state's looking for a champion, and we can start marshaling others behind Maryland ACEP.
I like it. This is certainly a good forum to start with that, and we can definitely advertise within our Maryland ACEP community, because I agree. I mean, this is, as has been pointed out, this is a crisis. This is a chance for us to lead our patients to life-saving interventions, and if we lead the country and set a good example, that's not terrible either. I'm okay with that. So again, I want to specifically thank our speaker panel here. Thank you so much on behalf, for myself and Dr. Mann, for the Practice Management Committee in Maryland ACEP. Really appreciate your expertise here. As mentioned, we are going to kind of disseminate this to all of Maryland ACEP, and thank you to everyone who had a chance, to everyone else who had a chance to participate today and attend live. But hope everyone has a great Monday, and thank you again.